we're going to describe how to do a bedside echo in a pinch. You can notice I have the COVID-19 look going on here. So we're going to pretend we're in the emergency department or we're in the ICU, and you've been called upon to assess this patient's left ventricular function, and you go grab the echo machine. So we have a Sonosite echo machine here. This is the kind we have at the Summit Emergency Department. Slightly different unit up in our ICU, and everybody might be a little bit different, but I think this Sonosite that we're going to demonstrate today is the most common that we see around the region. So we'll switch our echo machine on, and that's probably the hardest part for these different echo machines, is finding the power button, okay? And then we need to know what probe we're going to use. So we want to use a cardiac probe, which looks like this, and sometimes it takes you looking at the actual machine and identifying the probe. You want to make sure it's this probe and not the linear vascular probe that we use for vascular access. So it's a little more narrow. And you can see where that's attached. Now this is a really nice unit, the Sonosite. We can actually go down here and you can select the transducer and exam type. So the first thing after it powers up is you hit select, and then you pick the cardiac probe, and it looks like it's already selected here. You can move this down if you need to, or select another one, but there's cardiac, and then you just hit the scan button and you should be ready to roll. So it's very simple with this Sonosite system. Okay, so we'll go ahead and begin scanning. This is our victim. This is a patient in shock, and I think it's important to understand that this isn't going to be like doing a formal echo, because the patient, you can rarely get them up in their left lateral position like you like them to be for the apical views and echo. So we're going to be usually doing this in a supine position. And remembering from the slides that we talked about earlier, you want to find the little dot on your probe, and that's going to be your marker for when you're imaging. To do parasternal views, we're going to be down here on the chest, about the third, fourth intercostal space adjacent to the sternum. And then for the apical views, we're going to be up around here at the point of maximal impulse, which is usually right below the nipple. But we're going to work with that and look around. So let's start off by just imaging in the parasternal view here, okay? And I've got my dot pointed towards the right shoulder, so that's going to give us the parasternal long axis view that we're all used to seeing with echo. And let's put the gain up a little bit. So looking at this, if I just shove this little slider over, we're going to get better view. That's the gain down there. The longitudinal axis or the vertical axis is actually the depth. So we can change that too. We can kind of come down and get more depth if we want it, or we can make the image bigger by decreasing the depth here on the vertical axis. Okay, so you can see my hands aren't that steady, but we get a nice view. This is an unusually great view of the parasternal long axis in this patient, who is obviously not in shock, but going to look a lot different if he is. So to get the next view, which is the short axis view, you just turn your transducer 90 degrees, and you have the dot now going towards the left shoulder, okay? And that gives you this nice image of the LV in short axis, the so-called donut view. It's right below the mitral valve in this case. If I come over, I can get down a little bit lower. And you can see that he's got nice symmetric LV contraction. And then if you just rotate up, sort of up by the, up more towards the top of the heart, you're going to start seeing the aortic valve come in. You can do all that. But you know, honestly, the main things from these views for us is going to be to assess LV function. Here we're getting a real good idea of that. So we take our transducer now, get a little bit more gel on it. Again, remembering where your dot is. Very important, the dot goes to 3 o'clock when you come down here at the apical view, okay? So you're pointing down at about 3 o'clock, so it's And then we just rotate up. I'm right below the nipple, and we got a nice view of his LV. We also can see his RV pretty well over there. At least I think I can see it pretty well. You know it's not at least some gigantic RV like you might see in acute pulmonary embolism, which is a huge help when you're in the ER. So you can see the kind of nice views we're getting. We know this patient does not have any LV dysfunction, so we've kind of taken shock off the table. Nice view of the mitral valve. In a moment, we'll show you the things we do to look for mitral regurgitation with color flow imaging, which I think will be helpful. Now, in this case, we could probably increase our depth a little bit so that we can see a little bit more of the left atrium. And we did that, and you can kind of see everything. I'm not getting exactly right angles, but the mitral valve looks pretty good. And then Elaine, I'm going to have you just put a little color in that if you would, and just maybe tell us how we do that. There's a little button over here on the side that says C.
So yeah, we hit the C. There's M for MO, D for Doppler, C for color. I just hit color. I, with my finger, moved the color bar over to the left atrium. You can see a little bit of trace.
Yeah, there's a little trace MR, as we see in almost everybody, but there's certainly not wide open MR, which too bad we don't really actually have a shock patient who has wide open MR. But everybody knows what that looks like, at least the cardiologist in the audience. The last angle that we need to do or orientation is the subcostal view. So we find the xiphoid process and come about 2 centimeters below that. And then we kind of angle up, and you can start to see the heart, and we have pretty good depth from that last change we made. And there you see the RV really well. And then to look at the IVC, we just basically orient the probe 90 degrees, and it brings the IVC into view, which if it's really big is going to show up really nice. Take a little sniff there, Rob. And you can see his IVC is nice and normal. Just sniff, man. Breathe normal. Good. So all good. So there's your, and this is also a great view, as everybody knows, for pericardial effusion. We basically, that's the exam that we want. The last thing that we want to talk about is just acquisition of images. And Elaine, why don't you show us how to do that on this machine in case we want to do that?
So there's a button down here at the bottom of the screen that says Save Video Clip. You just hit that one time and it will store the clip to the hard drive. If you have a still frame image, you can save an image in a still frame.
Okay, so we've got our images, and we're pretty much done. What I'd like to emphasize to everybody, because it's the thing that I'm going to forget, is where do you orient your transducer? Remember the dot on the top of the transducer. For parasternal, it's up towards the right shoulder for your initial long axis view, left shoulder for the short axis parasternal, 3 o'clock for apical views. So it's pointing right down at basically at the bed. And then you're just kind of moving around until you get an image in that general vicinity. It's a little different for everybody, but you can see. Now, if you really want to get fancy, you can orient it 90 degrees. The dot goes up towards the head, and you can get the apical 2 chamber, which is awfully hard to do in some people, but not in this patient. And you can get a pretty good image of the inferior wall if you're interested in that, as we can see here. So hope that helps. Hope the slide presentation helps, and maybe we can all become at least decent echocardiographers in the pinch now. Thank you for watching.
Hi, so it's Dr. Eric Johnson again. We're just going to briefly go over these slides at the end of the video presentation, just to review what we touched on during the video. Remember, this bedside echo is a limited study to help with clinical decision making, and it can be done as part of your physical exam. And I'd recommend that people go to the ER and just do this on everybody and just kind of get used to it. It's extremely useful in evaluating the causes of shock. So you can identify hypovolemic shock, tamponade, LV and RV failure, valvulopathies, and as we touched on, you can look at the RV. It often is helpful in the diagnosis for pulmonary embolism. So here's the equipment. Remember, finding the right probe is often one of the big challenges. You want that little square face there. It has orientation markers, both a linear line and a little dot there. You need the ultrasound machine, of course. There's the sonocyte, and you need gel. Remember, too, that you've got to identify the correct probe. The cardiac probe is square-faced as opposed to the linear probe that we use for femoral and radial access, shown on the right panel there. Finding the power button is often the most challenging aspect of this. So in the sonocyte that we demonstrated in our video, it's fairly easy. It's up in the upper right panel, but power the thing up. You can put in patient information if you want to. It's not crucial. If you're going to record something, you probably ought to put it in. Next step is to select the transducer, and on the sonocyte, you just go up to the top touch screen and you pick the transducer, hit that button. It brings up this transducer screen, and then you just select the cardiac probe. It's got nice little pictures of the probes there. But it's usually pretty self-explanatory. And once you've done it a few times, you get really used to this. Looking at that screen, once you get your cardiac probe selected, you'll get that sort of crescent-shaped screen. And on the horizontal axis is your gain control, a touch screen again. And that will increase your contrast. That image there is indicative of an image that's frozen, so you want to hit that freeze button down at the bottom. And that will give you the sort of snow appearance that is produced when you put gel on your probe. And then lastly, to increase or decrease your depth, go to the vertical axis shown on the right there and on the bottom screen, and you can decrease your depth for the skinny patients and increase your depth for the heavier patients, and depending on what view you're on. To archive image, to image archive, and also to select the imaging that you want to do. We're going to be mostly interested in the green button there, the 2D, so push that button. If you want to do a little color flow imaging, as we talked about in the video, you can hit the C button there. And then if you want to save a video clip, if you put in demographic information, you've got this view that's particularly outstanding, just hit that Save Video Clip button down at the bottom. Remember, the three main windows that we use are the parasternal window, long and short axis, the apical window number 2 there, right below the nipple, and the subcostal window. The parasternal long axis view, your probe markers are pointed towards the right shoulder. That gives you this nice long axis parasternal view shown on the right. And you can adjust the depth accordingly. The average parameters are shown there on the slide. For the short axis view, you just turn your transducer 90 degrees up towards the left shoulder, and you get the short axis parasternal view, which shows the LV in cross-section, the mitral valve in cross-section, and the aortic valve as you angle your probe higher up the heart. The apical four-chamber view is down at the nipple. You should put your probe just below the nipple, oriented with the marker at 3 o'clock or down towards the bed. And that brings up this nice four-chamber view with the LV, RV, and the 2 atria. This requires some manipulation, often requires more depth on your vertical axis. To obtain the atria on the screen, or if you want to just focus on the LV, you can decrease the depth. And then the subcostal view is the third view. This is down in the subxiphoid region, and initial view is with the marker at 3 o'clock, gives you the four-chamber subcostal view, which is often the only view you can get in some people, especially those with COPD. Very good for looking for pericardial effusion. Rotating the probe now 90 degrees up towards the head, you get the IVC view to look for IVC filling. And then finally, just talking about some of the older generation machines, this is just one example. This is a sonocyte with a lot of the buttons are old style. You don't have a touch screen, power button on the left panel. Transducer selection is usually in this machine is you push a button next to the transducer cord. So you identify the transducer and then push the button until the green light comes on. And then the depth control is a push button. You can see the gain control there on the left. That third panel over is a dial. So no touch screen in this case, but you get good images with these machines often, and that's all you really care about. So just go with it and do your best. And like I said, the best thing to do is to just do some of these on patients that you don't necessarily need to do them on, but just to get familiar with the control so that you're ready to go in the crunch. I want to give a special thanks to Elaine Shea, who was the overall producer and actually created these slides for me. Angela Broussard and Leslie Miles, two of our cath lab staff who provided the cinematography with their iPhones, and Rob Alonzo, one of our esteemed nurses in the cath lab who was the victim in the video. So good luck with your imaging. I hope this is going to help us all identify our patients who are critically ill in cardiogenic shock. This is Dr. Eric Johnson. Thanks.